My name is Dr. Clement Nguka. I am here today to say something about a fast heart. All along I've been talking about a slow heart rhythm or a slow heart beat, which we called a bradycardia. And all the conditions that we discussed, they were such that at the end you have a heart that is slow. Blocked hearts, for instance, we talked about that. But just as we said something about slow hearts causing symptoms like dizziness, fainting, by the same token, we can talk of fast hearts as causing symptoms like palpitations. You know, that word strikes terror to any doctor who's treating heart patients, to any heart specialist, to any cardiologist, to any electrophysiologist. It strikes terror. What's going on? A palpitation is not a disease. A palpitation is a symptom. When the patient says, "Man, I hear an abnormal beating of my heart. This is abnormal. I normally, as I'm sitting here right now, I don't feel my heart beating. I don't hear anything." But when the patient says, "Man, I don't know, my heart is beating abnormally. I don't know what's happening," that is a palpitation. Well, palpitations don't really kill as palpitations. Same as a murmur. Murmur will not kill you because that's a symptom of something that's underlying. And the heart specialist is worried about serious events like VT, ventricular tachycardia. He's worried about those things. That's why, can you hear your heart? But we must look out as healthcare workers not to send patients to a specialist when a patient is just pregnant. Of course, there will be a palpitation when the patient is pregnant. There will be a fast heart rate when the patient is pregnant. But we don't want to send a patient to a specialist when the patient has got fever. Fever will cause the heart rate to increase. So that will be a palpitation in a way, right? But there's something that happens when there's a palpitation. The patient gets worried. And that stressful situation causes adrenaline to be released, which causes more palpitation. So the more the palpitation is, the more the patient worries, the more adrenaline is being released. So this is a problem. It becomes a vicious cycle now, where there's this cardiac FM that is tuned in. Because the stressful situation produces a palpitation. The palpitation, the more the palpitation, the more stress. As that stressful situation gives rise to a release of adrenaline. And therefore, but this is just a palpitation. What we need, when you tell the patient, or perhaps you investigate the patient, you find that there's nothing wrong. There's nothing wrong with the heart of the patient. It is because of the adrenaline that has been released, a stressful situation that gives rise to this cardiac FM. This vicious cycle. A patient is pregnant, and then the heart rate goes up. And when the heart rate goes up, the patient gets worried because, I feel my heartbeat. And, the more the patient palpitates. So the palpitation is now the cause of a release of adrenaline. So that when adrenaline is released, it means more palpitation. So more palpitation. So this becomes a vicious cycle. Whereas there are conditions which can actually cause a palpitation. Not really cause the fast heart rate. Like I gave an example of, so we need to see a palpitation as a symptom. We need to see a palpitation as a symptom of something that is. But then, what could be happening that would cause a fast heart rate? For instance, there's something called hypertrophic cardiomyopathy, where the septum that separates the right from the left heart, it increases in size. It gets hypertrophied. It increases in size. When it increases in size, it disturbs the rhythm of the heart. It disturbs the rhythm. You get a fast heart rate and a very much disorganized heart rate. Hypertrophic cardiomyopathy. So that's what the heart specialist is thinking about when the patient, and that is why the heart specialist will ask the patient, can you tap to show me your heart rate? That's an important question, because a patient can tap and show you that, hey man, it goes like this, it goes like that, it goes like that. It goes maybe to 100, 110, 110. Oh well, and then the heart specialist will have an idea that we're talking about just, a sinus tachycardia, a sinus tachycardia. But if the patient says, meaning that the rate is high, it goes to something like 170, it goes to something like 200, and all that. Then the heart specialist has to look at it and check. Are we talking VTAC here? What are we talking? Are we talking hypertrophic cardiomyopathy? What are we talking? See, from the tapping, the heart specialist can get an idea of what is happening. So it's important to talk to the patient and get to know exactly what the patient is describing, because it happens to the patient knows exactly what is happening. Whereas the investigation that normally is normally done is that of looking at the arteries. Do an X-ray of the arteries and do a scan of the arteries and have an idea if there's anything growing there. If there is something growing, then we know that, well, it could be. I mean, remember, you can get this even with an obstructed blood vessel, artery, an obstructed blood, which would give rise to what? To a myocardial infarction or a heart attack. It will give rise to to a tachycardia. A tachycardia because of a damaged heart. Because of a damaged heart. So one needs to know what is actually happening. Is it a damaged valve? Is it a damage? If it's a damaged, myocardium, it can actually you can get a tachycardia. You can get a VTAC, that is ventricular tachycardia, and one can sort of use defibrillators to find out to get this patient back to normal. You can use a defibrillator, an automatic a defibrillator, to get the patient back to normal. You can get the patient back to normal sometimes if you use those defibrillators, like an automatic implanted uh, defibrillator, and then it can get the patient back to a normal sinus rhythm, and you take the patient from a VTAC to a normal sinus rhythm. And it is important to know that the patient, it was not just a palpitation without any, it was not just a symptom of, because it was promoted by adrenaline, that is as a chemical known as adrenaline, that causes the heart rate to increase. It's not just that. It is because of a medical condition like VTAC, ventricular tachycardia, is it a chaotic, is it a chaotic rhythm where you can think of, when you can think of atrial fibrillation, you think of atrial fibrillation. Was it a chaotic rhythm? Was it, you can't make out what it is. When the atria, they are fibrillating, they stopped actually beating, and to move to move from something like 300 beats per minute when it's an atrial flutter, and you move to 600 beats per minute when it is your atrial tachycardia, your atrial flutter, your atrial fibrillation. There's atrial flutter and atrial fibrillation. These are all, it it shows that the it's a disturbance of the rhythm. It's a disturbance of the rhythm. Disturbance of the rhythm is not only, it doesn't only give rise to a bradycardia, it can also give rise to a tachycardia. We got a bradycardia from a myocardial infarction or a heart attack, but now still with a heart attack, you can still produce, you damage the myocardium to an extent of getting the atrial, the atrium to stop beating, and it does what is known as atrial fibrillation when it has stopped beating. And think of 600 beats per minute. It's only, it's not really, it's trembling. It is not really beating, but it is trembling at 600 beats per minute. And you tell me, remember, this same heart has got to deliver blood to the ventricles. Is it going to be able to deliver blood to the ventricles? It is not going to deliver blood. That is why you get a thrombus formation when there's an atrial fibrillation. You get thrombus formation in there. And then that's a potential for a stroke. So now, because of this, so when there's a disturbance of rhythm, you worried about those. You're worried about those conditions, like if a small piece gets broken from the thrombus, and it gets to the ventricle, and it is propagated to the brain. If it goes to the brain, you know that those cerebral arteries can be small, and some of them they branch into capillaries, and those small capillaries. So there will be a block there, and if there's an obstruction there, then you expect a stroke. You expect a stroke, and that's bad. It's all because of a disturbance of rhythm. Disturbance of rhythm. That's important. You can disturb the rhythm using the atrial flutter. Atrial flutter, it's about 300 milligrams, 300 beats per minute, 300 beats per minute. And then if that increases to further to 600 beats per minute, and it's no longer now beating, but it is fibrillating. And when it's like that, then it has stopped beating. And when you say it has stopped beating, it means that the blood is going to be stagnant there in the atrial appendage. And when it's stagnant there in the atrial appendage, you're running a risk of a piece being broken off and dislodged and getting to the ventricle. And when it gets to the ventricle, it can be propagated to the brain. And when it's propagated to the brain, what are you expecting? You're expecting a stroke. So disturbances like rhythm disturbances like atrial flutter, atrial fibrillation, you are worried about a stroke. You worried about a stroke, and that's what you should. That is why people should take it seriously to say that I'm going to refer this patient to the cardiologist. I'm going to refer the patient to the electrophysiologist. I'm going to refer to the specialist, even the physicians. I'm going to refer to. I'm not going to, at a primary healthcare level. I'm not going to talk about that. I'm going to say, I am not going to try and manage this. It does not matter how much I know about drugs and stuff. I'm not going to manage. I'm going to send the patient over to the specialist for them to handle and decide what type of drugs are they going to use and what type of approach are they going to help this patient with, and all that. First of all, it would be good for you as a GP or as a clinician to say that I got to find out that the patient has got hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is something to grapple with. I mean, so that the specialist can deal with that hypertrophic cardiomyopathy. You are saying, but it would be really not right for you as a primary healthcare doctor to take a patient to the specialist when the patient is just pregnant, and so patient has got just a palpitation because of pregnancy. The patient has got a fever, and then the patient you send the patient over to no, those are not patients. I mean, you deal with the fever. I mean, you can make sure that you give anything that's going to lower. I mean, you have drugs that you can use to start from a Panado, for instance. Paracetamol can actually help that, that, and to bring the patient to the temperature of the patient down. And also it is important to realize that if a patient has got a palpitation, that patient mustn't worsen the palpitation by being scared or by being you need to be able to sort of cancel the patient so that the patient doesn't stress. Because if the patient stresses, you know that a chemical known as adrenaline is going to be liberated. And when it is liberated, what's going to happen? It's going to cause more palpitation. More palpitation. Because adrenaline is there to make sure that the heart goes faster. The rate, it increases the rate of the heart. And if you realize that as a healthcare worker, that's very good, because now you'll be able to counsel the patient, to say, or lull the patient, or calm the patient down, to say that, no man, no, your blood vessels are okay, so there's no problem. I mean, we've done an X-ray of your arteries. We've done your scan of your arteries. They are all okay. So there's no need for this. You talk to the patient, and then you can talk the patient down, and then the patient can, understand. So the point you are taking is that a palpitation is a symptom. A palpitation is not a disease. The patient is not sick, so to say. The patient, you can't refer the patient to the cardiologist. The cardiologist will just laugh it out and say, what's all this? Because, I mean, according to the tests, according to the examination findings, the the X-ray of the arteries has been done, and it's all normal. And the scan of the arteries has been done, it's all normal. So it means it's just adrenaline that was raising this. So that this is important, so that it is not hypertrophic cardiomyopathy, which is a serious condition. It is not VTAC, ventricular tachycardia. It's not VTAC, So it's important to understand those things, that conditions which would cause serious conditions like hypertrophic cardiomyopathy. I mean, that would cause a tachycardia, and that would cause, and the patient would really feel, disturbed and all that, because but the condition is a serious condition. That is why it is important. Serious conditions like that should be sent to the specialist. Thank you very much. Thank you very much. My point in that really I'd like us to understand is that of saying, I'm not going to refer a patient with a fever to the cardiologist because of the tachycardia, because of the palpitation that I saw. I'm not going to refer a patient who's just pregnant and refer that to the cardiologist. There's something wrong here. The heart is beating. No. I'm not going to refer. Patients who are taking stimulants like alcohol, for instance. I mean, the heart rate is going to increase. Stimulants. Stimulants. I don't know whether to call coffee a stimulant, but a stimulant that causes a tachycardia, that causes the patient to have an increased heart rate, and then such that the patient feels the tachycardia, so feels the palpitation, feels that we're not supposed to feel our heart, how the heart is beating, but if you worry about that, you must know that you are liberating adrenaline, and this chemical is going to cause the heart rate to be increased, and then it becomes a cardiac FM now. You're tuning into a cardiac FM where you are increasing. The more you stress, the more palpitations. The more you palpitations, the more you stress. The more you palpitation, the more you stress. Thank you very much. Thank you very much. We know now the patients who are going to refer a hypertrophic cardiomyopathy. We're going to refer a VTAC, ventricular tachycardia. Thank you. Bye-bye.